Imagine, if you will, trying to fix a leak in a standard garden hose.
Right. Sounds easy enough.
Yeah, but now imagine that hose is the width of a standard #2 pencil.
Oh, wow. Okay.
And you have to seal this leak from the inside using a needle that is literally as thin as a human hair. And you have to do it without poking all the way through the rubber wall.
I mean, that is just...
Oh, and one more thing. Sitting right in your way, actively blocking your path, is a tiny, highly inflamed raspberry.
Yeah, the sheer mechanics of trying to navigate that scenario are incredibly daunting. I mean, we are talking about microscopic margins of error here.
We really are. So today, we are taking a deep dive into the microanatomy of the female urethra. It is honestly a topic that rarely gets the detailed attention it deserves when we talk about pelvic health.
It really doesn't.
We've got a fascinating stack of medical literature in front of us for you today. We're looking at case reports of bizarre anatomical anomalies, some really cutting-edge clinical trial data on using platelet-rich plasma, or PRP, to cure incontinence, and the highly specific surgical guidelines for how doctors attempt to fix this biological plumbing.
Right, because it is plumbing, but it's alive.
Exactly. So the mission of this deep dive is for you to understand how these tiny structures work, how they fail, and the incredible literal collision that happens when doctors try to navigate a needle through tissue that has fundamentally changed its shape. Okay, let's unpack this.
To really grasp the stakes of those tight margins you mentioned, we have to establish the baseline of the anatomy itself. The female urethra is an incredibly small, very specialized structure.
Right.
We are looking at a tube that is roughly 4 centimeters long and only about 8 millimeters in diameter.
Wait, just 8 millimeters? I mean, I wasn't kidding about the pencil analogy earlier.
You really weren't. It is essentially a capillary scale environment. It runs parallel to the anterior vaginal wall, going from the internal opening at the bladder neck down to the external opening, the meatus, in the vestibule.
Okay, got it.
But, we can't think of it as just a static, empty plastic tube. It is a highly dynamic organ. It's surrounded by this intricate web of muscular and ligamentous structures.
Because it has to hold back pressure.
Exactly. And there are numerous small glands that secrete into the lining to keep it healthy, including the periurethral skein glands, which, biologically speaking, are actually homologous to the male prostate.
Oh, that's wild. I didn't realize that.
Yeah, it's fascinating. But all of these structures, they have to work in perfect microscopic harmony to maintain continence.
So what happens when that harmony breaks down?
Yeah.
Because the literature we pulled highlights two specific, very visually distinct anomalies that can pop up.
Right, the structural failures.
Yeah, the first one is called urethral prolapse.
So prolapse is, well, it's an everversion of the tissue.
Like turning inside out.
Basically, yeah. The urethral mucosa essentially turns inside out. When you look at the clinical literature, doctors describe it visually as a donut-shaped mass protruding from the urethra. It involves the entire circumference of the opening.
The whole thing just pushes out.
Right. And it's largely a pediatric issue. It's specifically seen in young patients of African descent who actually make up over 90% of the pediatric cases. Or, on the flip side, it appears much later in life in postmenopausal women.
Which is interesting because I noticed in the sources that it is exceedingly rare in healthy premenopausal women, like almost unheard of.
Exceedingly rare. I mean, the literature notes only 4 such cases described to date.
Wow, just 4.
Yeah, and one of those cases involved a 38-year-old patient who had a 46XY karyotype.
Wait, so genetically male?
Genetically, yes, this patient had XY chromosomes, but due to androgen insensitivity syndrome, they developed female anatomy. So that genetic outlier just highlights how unusual it is for robust premenopausal tissue to structurally fail in this specific way.
That makes sense. So that's the donut. But the second anomaly is far more common. And visually, it's a completely different shape. It's called a urethral caruncle. And I have to say, I love the historical footnote on this one in the sources.
Oh, from the 1700s, right?
Yes. It was first described all the way back in 1750 by a physician named Samuel Sharp. And today, it remains the most common benign tumor of the female urethra.
So unlike that circumferential donut of a prolapse, a caruncle is a very highly localized lesion. It almost always sits at the posterior lip of the distal urethral mucosa.
Which means the back edge, right?
Right, so if you imagine the urethral opening as a clock face, The caruncle sets up shop right at the 6 o'clock position.
Okay, visual tracking with you.
And visually, it typically presents as a soft, bright red, basically a raspberry-like nodule that protrudes from the opening.
Now, if you were listening and wondering why a tiny, say, 1 centimeter bump matters at all, let's go back to that flexible garden hose. If you have an 8 millimeter hose, a 1 centimeter obstruction sitting right at the very tip acts exactly like a rubber stopper.
It plugs the whole system.
Exactly. It can cause bleeding, intense pain during urination, or just catastrophic blockages.
And we actually have a really visceral example of that in the case reports we reviewed for this. There was a 39-year-old woman who arrived at an emergency department experiencing acute urinary retention.
Meaning she couldn't pee at all.
Right. She had been completely unable to urinate for 12 hours.
Oh my God. 12 hours of a constantly filling bladder. I mean, the physical pressure of that is hard to even fathom.
Yeah, she was in agonizing abdominal pain. She had a palpable, highly distended bladder. And when they did an ultrasound, it revealed bilateral grade 1 ectasia.
What does that mean practically?
Basically, her bladder was so incredibly full that the back pressure of the urine was forcing fluid back up the ureters, causing her kidneys to physically swell.
From a tiny little bump.
The culprit behind this massive system failure was a urethral caruncle measuring just 1.5 by 2 centimeters.
That is bonkers.
It was protruding from that posterior wall 6 o'clock spot and completely blocking the exit. The emergency physicians had to insert a small 12 French catheter past the obstruction just to drain the bladder, and they emptied approximately 900 cc's of urine.
900 cc. That is almost a full liter of fluid trapped behind a tiny fleshy raspberry.
Yeah.
I mean, they ultimately had to surgically remove it, right?
They did. They performed a cystoarthroscopy under spinal anesthesia to excise the lesion. And when doctors looked at this removed tissue under a microscope, it wasn't calm, normal mucosa.
It wasn't just skin.
No.
Now,
The pathology report describes inflammatory granulation tissue covered in hyperplastic urothelium. To put that in mechanical terms, it was just an angry, chaotic tangle of swollen blood vessels and wildly multiplying cells.
a biological traffic jam right at the exit pipe.
Precisely. And what's fascinating here is that what connects both the donut prolapse and this angry raspberry caruncle is the underlying structural failure. And the root cause of that failure is estrogen deficiency.
Estrogen hormone.
Yeah, estrogen is the crucial maintenance hormone for urogenital tissues. It keeps them plump, flexible, well vascularized, and physically supported. When estrogen levels plummet, which typically happens after menopause, those tissues undergo atrophy.
They shrink up.
They shrink. The structural integrity weakens. And this loss of physical support is exactly what allows the mucosa to either slide out into that prolapsed donut or become irritated and form that inflamed caruncle at the 6 o'clock mark.
So it's a localized structural collapse brought on by a systemic hormonal shift, which brings us perfectly to the other side of this physiological coin. We just looked at what happens when the structural failure blocks the pipe. But what happens when the structural failure means the pipe won't close?
Right, the leakage problem.
Yeah. When the hose constantly leaks, this is stress urinary incontinence, or SUI. You cough, you laugh, you sneeze, and urine escapes. If the surrounding anatomy is too weak to pinch the pipe shut, how do doctors fix it without resorting to major invasive sling surgeries?
Well, the traditional minimally invasive approach relies on urethral bulking agents. These are synthetic biocompatible materials. We're talking brand names like Durasphere, Coaptite, or Macroplasty.
Like a medical-grade filler.
Basically, the mechanical logic is very straightforward. Physicians inject these thick gels directly into the walls of the urethra. This creates a localized volume effect.
Got it.
So the tissue bulges inward, closing the gap in the center of the tube. This allows the walls of the urethra to touch and create a watertight seal against each other, a physical state that we call coaptation.
It functions exactly like injecting synthetic caulk into the lining of the hose. The opening swells shut, but remains just flexible enough to be pushed open by the pressure of urine when it is actually time to go.
That's the ideal outcome, yes.
But our sources show this fascinating shift happening right now in urogynecology. They aren't just relying on synthetic caulk anymore. They're actively investigating PRP, platelet-rich plasma.
Yeah, PRP represents a massive pivot from mechanical space filling to biological regeneration.
Hmm.
It is already utilized extensively in sports medicine for, healing torn tendons and in dermatology for tissue repair.
Right, the vampire facials.
Exactly. But applying it to the weakened urethral sphincter for SUI is this emerging, albeit currently off-label, frontier of global clinical research. And the key difference here is that PRP is an autologous biological therapy.
Meaning the medicine comes directly from the patient's own body.
Right.
So for you listening, the procedure starts with drawing the patient's blood and putting it into a centrifuge. The sources mention spinning it at something like 3,400 RPM for 15 minutes. And the centrifugal force separates the blood into distinct layers. Heavy red blood cells drop to the bottom, a separating gel sits in the middle, and sitting at the top is this concentrated golden platelet pellet.
And that plasma is the payload.
It is.
Because that golden plasma is absolutely packed with platelet-derived growth factors and bioactive mediators. When you inject a synthetic bulking agent, it just sits there occupying physical space. And over time, it can degrade or even migrate.
It's just a placeholder.
Exactly. But when you inject PRP, the theory is that those growth factors act as biological distress signals. They recruit stem cells to the area. They initiate angiogenesis, which is the formation of brand new blood vessel networks.
Wow.
The ultimate goal is to genuinely regenerate the muscle and nerve tissue of the weakened urethral sphincter, restoring its natural ability to contract and hold urine.
I mean, the theory of actually regenerating tissue is incredible, but I want to push back on the logistics of the delivery system here.
Yeah.
We established at the very beginning that this tube is 8 millimeters wide, a pencil.
Yes.
How do you maneuver a needle into an 8-millimeter pipe to inject thick synthetic gels or liquid blood plasma without completely tearing apart the fragile structure you were trying to save?
It demands an extraordinary level of anatomical mapping. I mean, the injections are typically placed about 1 to 1.5 centimeters proximal to the external meatus.
So you are working just barely inside the opening of the urethra.
Barely inside. And the delivery system itself is incredibly small. Physicians use a 27-gauge or even a 30-gauge needle. For context, a 30-gauge needle is essentially the diameter of a couple of strands of human hair.
Okay, but even with the needle that thin, they can't just poke blindly into the tissue. They are hunting for a very specific layer, right? The submucosa.
Right. The urethral wall is constructed in very distinct layers. The needle must navigate into the submucosal space, which is this spongy connective tissue layer sitting right beneath the delicate surface lining, but above the actual sphincter muscle.
So it's sandwiched in there.
Yes. And there are two primary techniques used to access this space: transurethral and periurethral.
Let's break those down visually for the listener. Transurethral basically means going from the inside out. The physician inserts a tiny camera, a cystoscope, directly into the urethra. They feed a specialized thermoplastic injection catheter through the scope, and then they physically angle the needle to poke outward into the urethral wall.
Exactly. And the procedural guidelines mention using a 0, 12, or 25-degree lens on the camera so the doctor can literally watch the needle pierce the lining and enter the tissue in real time.
Okay, so that's the inside-out method. But the alternative is the periurethral approach, which comes from the outside in.
Right. The needle is inserted through the perineal skin right next to the urethral opening, often entering at the 4 o'clock and 8 o'clock positions.
Okay, tracking the clock again.
The physician then advances the needle deeply, keeping it parallel to the urethra, just sliding it downward within the wall itself. They rely heavily on cystoscopic guidance, or transvaginal ultrasound, to watch the needle move through the tissue planes beneath the mucosa.
You know, the periurethral approach is where my brain just stalls out a bit. It's basically like holding a paper cup and trying to slide a thin straw straight down inside the actual cardboard layers of the cup itself.
Oh, that's a great visual.
Yeah, you have to slide down the center of the cardboard wall without accidentally piercing through to the liquid inside the cup, without poking out the outside of the cup into the surrounding pelvis.
The paper cup analogy perfectly captures the sheer difficulty of the task.
Mm-hmm.
You are navigating a microscopic tissue plane. And with the experimental nature of PRP, the protocols for how much to inject and exactly where are still highly variable.
Really? There's no standard yet?
No, not at all. A trial by Eng et al. Mapped out a robust protocol injecting 25 milliliters of PRP directly into the external sphincter distributed across 4 sessions. Meanwhile, other clinical studies in the literature used a total of just 5 milliliters for the entire treatment.
That's a huge difference.
Yeah.
But I did see one very specific protocol in the research that mapped out the anatomy using that clock face we talked about earlier.
Yeah.
They injected 1 milliliter of PRP at the 12, 3, and 9 o'clock positions in the submucosa. Then they deposited a larger 2 milliliter dose right at the 6 o'clock position to ensure homogeneous coverage of that posterior wall.
Which brings up the crucial variable of failure. This raises an important question. What happens if the physician's precision slips? What happens if that hair-thin needle accidentally penetrates the urethral lining and pokes into the open lumen, or plunges too deep and punctures the bladder?
The medicine, whether it's synthetic caulk or golden plasma, it just leaks out.
Medical professionals term this extravasation. If the material leaks into the bladder or escapes back out the urethra, the mechanical volume effect is completely lost. You fail to achieve coaptation, and the patient's incontinence is not resolved.
It's all for nothing.
Worse than nothing sometimes. If a synthetic bulking agent is mistakenly injected too distally, meaning too close to the exit, into the external sphincter rather than the proximal submucosa, the material can cause severe nerve pain and irritative voiding symptoms that essentially mimic a constant urinary tract infection.
Oh, that sounds miserable. So precision isn't just a goal. It is an absolute requirement. You cannot deviate from that submucosal layer of cardboard. Which means we have finally arrived at the major anatomical collision course hidden in these sources.
Here we go.
The question we've been building toward this entire time: how does the presence of an active urethral caruncle alter the needle trajectory doing periurethral infiltration?
Okay.
We'll put the puzzle pieces together for you. We established that the inflammatory raspberry caruncle lives almost exclusively on the posterior wall of the urethra, the 6 o'clock position.
Right.
We also just established that treating incontinence with PRP or bulking agents relies heavily on targeting the 4, 6, and 8 o'clock periurethral zones.
The geography overlaps perfectly. The lesion sits on the exact real estate the needle needs to traverse.
So mechanically speaking, if a physician is utilizing the periurethral approach, trying to slide that flexible needle parallel to the urethra, how does a bump at 6 o'clock actually ruin a needle path?
It all comes down to the physics of tissue density and resistance. Think back to sliding a needle through the soft cardboard of your paper cup. In a healthy urethra, the submucosal space is composed of a smooth, predictable, loose fibroblastic stroma. The needle glides through it because the tissue yields.
It makes way for it.
Exactly. But a caruncle is not just a bump sitting on the surface of the skin, it is deeply rooted in the tissue.
Right, we said it's an active tumor.
It is a dense, tangled root system of blood vessels, inflamed cells, and hyperplastic tissue. The normal soft space at the 6 o'clock position is effectively gone, replaced by a fibrous knot. So when the physician advances the hair-thin, highly flexible needle parallel to the urethra, the needle hits that dense knot of tissue.
And it bounces off.
Physics dictates that the flexible metal will take the path of least resistance. It cannot easily push through the dense tumor, so it bends. The needle physically deflects out of the proper submucosal layer, driven entirely off course by the dense mass of the caruncle.
And the sources actually provide a wild, documented case of this exact deflection happening in real life.
They do. It's a fascinating report.
There is a case report of a patient who had a urethral caruncle that stubbornly refused to respond to the standard treatment of topical estrogen creams. So the doctors eventually brought her in to surgically excise the lesion. When the pathology lab sliced open the removed caruncle to examine it, they found a synthetic urethral bulking agent trapped inside the caruncle.
If we connect this to the bigger picture, it is a profound example of procedural failure dictated by altered anatomy. The treating physician was attempting to cure the patient's stress urinary incontinence. They utilized a periurethral or transurethral approach, aiming for the submucosa at 6 o'clock. But because the caruncle's dense root system distorted the local tissue density, the physician unknowingly missed the tissue plane completely.
The needle bent. They thought they were injecting the caulk into the soft cardboard wall of the hose, but the needle had deflected directly into the rubber stopper.
Exactly. They deployed the bulking material directly into the benign tumor. And the clinical fallout from this deflection is really twofold. First, the incontinence treatment was rendered completely useless.
Because it wasn't in the wall.
Right. The material didn't bulge the urethral wall inward to create coaptation. It just inflated a benign tumor sitting on the outside of the opening. And second, deploying a foreign synthetic substance into an already inflamed, highly vascular caruncle triggered a massive localized inflammatory response.
Just made it way angrier.
This foreign body reaction likely explains exactly why the caruncle became so agitated that it stopped responding to topical estrogen and ultimately required surgical excision.
If you've ever wondered why pre-procedure examinations are vital before a doctor picks up a needle, this is the ultimate case study. A physician cannot go in blind based on just a textbook understanding of anatomy.
No, they really can't.
A simple visual inspection to identify a red raspberry-like nodule at 6 o'clock, or utilizing transvaginal ultrasound or cystoscopy to actively map the density of the tissue planes before injecting. It is literally the difference between curing a patient's incontinence and accidentally injecting synthetic caulk into an inflamed tumor.
It underscores the absolute necessity of treating the whole anatomical environment rather than an isolated symptom. I mean, if there is an estrogen deficiency-driven lesion occupying the 6 o'clock position, the physical mechanics of the tissue have changed.
The map is different.
You cannot safely perform a millimeter-precise submucosal injection in that zone until the local pathology is addressed.
It's just wild. I mean, just marvel at the sheer scale of the engineering happening inside this 4-centimeter structure. On one hand, a 1.5-centimeter caruncle can act as a physical dam, causing a catastrophic 900 cc backup of urine that swells the kidneys.
Yes.
And on the other hand, physicians are attempting to navigate hair-thin needles into microscopic layers of cardboard-like tissue, dodging fibrous tumors, all to cure incontinence using centrifuge blood plasma. It really is a masterclass in microanatomy.
The biological complexity is staggering. And looking at the trajectory of the research, it leaves us with one deeply intriguing thread to pull.
Oh.
While we know that systemic estrogen drops cause the tissue atrophy and structural weakness that lead to caruncles forming.
Right. The thinning of the tissues.
And we spent a lot of time exploring how PRP is being actively injected into these exact same periurethral tissues to recruit stem cells, promote angiogenesis, and regenerate the tissue to cure incontinence.
Wait. Where are you going with this?
If PRP successfully initiates tissue regeneration and rebuilds those vascular networks, could the localized growth factors in a PRP injection eventually evolve from an incontinence treatment into a non-surgical therapy to reverse the atrophy and cure the caruncles themselves?
Oh, wow.
Using the very treatment that currently gets deflected by the tumor to simultaneously heal the structural defect that caused the tumor in the first place? That is an absolutely brilliant question.
It's theoretically possible. It is definitely something to keep an eye on as the clinical trials around platelet-rich plasma continue to evolve. Thank you so much for joining us on this deep dive. Keep questioning the incredible mechanics of the human body, because as we learned today, fixing a leaky pipe sometimes requires navigating a microscopic tissue plane with a hair-thin needle, all while dodging a hidden raspberry. We will catch you next time.